and then we'll let you. So we have Dr. Caretti here with us, who's Division Director of Interventional Radiology. This is a much appreciated and probably much needed talk for our service. We have not an inconsequential number of post-IR patients on our service. So we'll have a brief overview of kind of common IR procedures and things we need to monitor for afterwards. So with that, I'll let you take it away.
Okay, great. Thanks so much. Yeah, I'm thrilled to be here. I wish I could see and meet everybody in person. I know over the last year, I have met some people, but it's been challenging with our circumstances. And I came during the pandemic. So it was an interesting time to transition, but I have met some people and I'm looking forward to meeting others. Any issues that ever come up, I'm gonna have my contact info on the slide. So feel free to reach out to me directly. Just sharing my screen here, sorry. Always tricky when I'm trying to go into presentation mode. Hopefully I can still see this. For some reason it's giving me trouble. You guys are hiding from me for some reason. 1 second. I might have to just share it in here and hopefully it'll, let's see. I bet you're seeing it in not presentation mode, is that right?
Yeah, that's fine. We can see it pretty well. There we go. That's good enough.
You can see it now. Okay. I don't have any side notes or anything, but sorry if you're seeing it in an odd form. Okay. So I'm going to talk to you about some admissions that we send from IR procedures and specifically about just really brief presentation of the procedure itself and some highlights of what patients need in post-procedure care. We have had a major push over the last several years in all places in IR, not just here, to try to get patients out the same day and not require a bed. And that's only been emphasized more, obviously, during the pandemic and needing bed preservation for COVID patients. So we do our best not to actually send patients when possible, but we really appreciate your services when we need to keep patients overnight unexpectedly. And that happens not infrequently, as you said. These are my disclosures. And what we're going to talk about, just so you know, it's a total of 24 slides, and that includes the intro and the thank you. So not a lot of material, so bear with me. But we're going to talk about the common IR procedure patients submitted to your service. We're going to describe basic procedure elements for each of the common admissions, and then talk about potential complications and post-procedure needs. And then lastly, just basically open it up to questions and discussion for any improvements in procedural workflow and discharge. The specific procedures that I want to talk about today are urinary drainage, biliary drainage, embolization, and ablation. And unfortunately, we do, 120 or so very specific procedures in IR, so they're all different. And even within the embolization category, for instance, there's just so many different organs and tumors that we embolize, and not all have the same needs post-procedure. But I thought these were some broad categories that we could discuss and, talk about the commonalities between them. So for urinary drainage, usually we do this because of obstruction, meaning the patient has some kind of anatomical blockage, whether it be a stone somewhere between the kidney and the bladder, or a mass, and that can even be below the bladder, such as the prostate. Or we do it for diversion. So the patient, we're trying to keep some area from being wet, basically, from being, from urine soaking it, whether it be a fistula, so like a vesicovaginal fistula, or it's a leak from some damage to the ureter for some reason. So sometimes we place nephrostomy tubes for diversion and sometimes for obstruction. Within this category, we have two basic procedures. One is nephrostomy and one is what's called a nephroureterostomy. And sorry if this seems really basic, but I just think a lot of times, I know before I went into IR, I really didn't understand some of the nuanced differences between these. So I'm just going to explain it the way that I would have wanted it explained. And if you think it's basic, then more power to you. I'm glad. Hopefully reiteration will help. But one of the things that, that we do again is nephrostomy and nephroureterostomy. And you can also hear those referred to as nephroureteral stents, which just makes things even more confusing because it's different than a ureteral stent that you hear about from urology. So essentially a tube is placed from the patient's back into the kidney. And a nephrostomy tube terminates in the kidney itself, so in the renal pelvis collecting system, and a nephroureterostomy tube terminates in the bladder. Remember that a nephroureterostomy tube can be to a bag or capped, and that's because if you look at these pictures here, this is the nephrostomy tube, so it goes in and you get that pigtail in the kidney, whereas a nephroureteral tube goes into the kidney. There's a loop there in the kidney for drainage of whatever is happening in the kidney itself. Then there's a tube that goes all the way down to the bladder and another loop there. So in other words, if there's a blockage somewhere between these two, we can place this type of tube to where you get drainage from this pigtail, it goes through the stent and it comes and excretes into the bladder. So you can bypass the blockage essentially. The difference between these two is that a nephrostomy tube, except in really rare circumstances, unusual hospice type situations or a few other things, this is always going to be to a bag because there's no way to divert away from the blockage unless you divert it to a bag. A nephroureteral tube can sometimes be capped and the patient can be without bag because there's a conduit from the kidney to the bladder that allows for drainage the appropriate way, the way the body normally does it. So you might ask, how does a nephroureterostomy tube differ from a ureteral stent that urology places? And the main difference, I'll just go back to the slide, is that with the urology tube, the stents, they're from the kidney to the bladder, but there's no external portion. Meaning if a patient's tube all of a sudden gets blocked, their stent gets blocked, there's no way to attach it to a bag. And so then they may ask for a nephrostomy or a nephroureteral stent. So there's an advantage to having a ureteral entire internal stent, of course, because a patient doesn't have to deal with a bag or it being retracted and all that kind of stuff. Major advantage, and that's why they're preferred most of the time. However, there's no pop-off mechanism. So a nephroureteral stent or a nephroureteral catheter is sometimes useful for patients who it's unclear whether they're going to survive a or be able to manage with a ureteral stent. So it's sort of a safety mechanism. And sometimes when they pass that test, we may progress to a ureteral stent. Another thing I'll point out is that if the blockage is the prostate, so below the bladder, no matter whether we extend a nephrostomy tube to a nephroureteral stent or not, that patient is never going to drain normal, right? Because the blockage is actually at the urethra level. So we can never cap those tubes for the most part. They're always, even if they have this nephroureteral tube, they're going to be to a bag because their urine has to come out the backside. It can't go through the blockage of the prostate. So just one other point I wanted to make. So what are the important things to consider after placing either a nephrostomy tube or a nephroureteral catheter? Some of the more typical things that can happen post-procedure are we may experience transient bacteremia or even urosepsis. The patient may have bleeding or the patient may have tube dislodgement. So with regard to transient bacteremia, this is typically very shortly after the procedure, and sometimes they don't even make it out of, and oftentimes don't even make it out of our post-procedure area or to your service before they have this reaction. A lot of times, because they have this reaction, may be the reason why we admit to you, so that we make sure that they do, that they're over this and it is transient and that they do well overnight. Typical signs of this are fever, tachycardia, and altered mental status. Bleeding, hematuria is very normal with nephrostomy tubes. These are obviously vascular organs that we cross the capsule and into the meat of the kidney and then into the collecting system. So we often see hematuria. You know, when you're seeing sort of a fruit punch look where it's urine mixed in with bleeding, that's normal, or even a really dark color. But that should improve over the matter of days. You know, a week or so later, if a patient's still having, or even after 3 days, if that's not decreasing every single day, you know, then you may want to make sure their CBC is stable and make sure they're not having a drop in hemoglobin. But immediately, you know, they can show signs of tachycardia, low blood pressure, decreasing hemoglobin, of course, and altered mental status again. Tube dislodgement isn't typical right after a procedure, but can happen. And the signs of tube dislodgement are the inability to flush. It can be painful to flush their catheters. They can get leakage around the tube because it's not getting, the urine is backing along the track rather than being able to go through the tube itself. And of course, no output. It's tricky with urine because one, it depends on the patient's hydration status. It depends on what the other kidney is doing. If they have a tube in that side, there's all sorts of factors that are involved in this, but if their output changes from normal significantly, that's another sign. With this, abdominal films are not incredibly helpful. And if these tubes are severely retracted, then we often know that just by how much is outside of the back, right? So getting an abdominal film, we already know it's severely retracted, probably isn't going to help too much. If the tubes are suspected to be retracted a little bit, the abdominal film is probably not going to be enough to tell us whether they're really in or really out, because if they're just moved by a tiny bit, they're not accurate enough. So really, a lot of times the best thing to do here is just a non-contrast abdominal CT, and that's adequate to evaluate position. We really don't need a contrasted study for positioning anyway. So some key takeaways with nephrostomy tubes or nephroureteral tubes. Transient bacteremia is common. Typically what we need for this is antibiotics and supportive therapy, and a lot of times we've done that by the time we call you. We may need to increase the level of care if the patient really has urosepsis. Hematuria is also common. Again, we follow our tubes, but of course, always feel free to call us if it's not clearing over days, or if you have concern with the hemodynamics, and or the patient requires a transfusion at all. It's not normal to require a transfusion after nephrostomy tube placement, so we would want to know about that. In those circumstances, we may request a CTA if it's unclear whether it's arterial or venous, or what might be bleeding. So it sort of depends on the patient's creatinine and all those factors. So it's good to give us a call in those circumstances. Tube dysfunction should prompt imaging to confirm the tube position. Oh, and I thought that was a misspell, but it's just it's positioning. It's just hidden by my Zoom. There we go. But remember, nephroureteral tubes are a little bit confusing, right? Because they can drain internally. So even if they are to a bag, they have a conduit from the kidney all the way down to the bladder. So sometimes you're going to have a variation in output. They may just be draining the normal pathway via the tube into the bladder, and then the patient has urine output. So you really have to wonder when you're thinking about if a nephroureteral tube has an issue or is dislodged in some way, you have to really look for other signs of dysfunction. Is there new onset hydro with an ultrasound, or is creatinine changing? Or is there some other indication along the track of the tube that there's leakage or something that indicates other dysfunction? Usually we don't emergently change these tubes unless there's concern for infection, of course. So biliary drainage is going to sound a lot like nephrostomy tube drainage, and that's why I put it next in this discussion. So, I think there are a lot of similarities. When we put a biliary drain in, we usually do it for obstruction, and sometimes that's with infection, so cholangitis, or sometimes without. And the obstruction can be due to stones, can be strictures from prior surgery or some other benign stricture, or malignancy, of course. Sometimes we do these for diversion too, in the cases where someone's had, the most typical scenario is when someone's had surgery and there's a biliary leak and we need to divert bile from leaking in that post-surgical location. When we think about biliary drainage, it's slightly different than urinary tubes, only because the substance that comes out of a biliary drain is different than urine. So urine is thin. It often, it has enzymes in it that actually keep the tubes patent themselves without flushing them. Whereas biliary drains, the substance that comes out of them, can lead to a different host of problems because of the type of material it is, essentially, and it's more likely to clog a tube than a urinary catheter, for instance. I think this was one of the more confusing things. I remember being a resident and trying to understand the difference between external and external drains. I think that language is very confusing to begin with, but those are the names of them. So there's external drains and there's internal external drains. And so the difference is essentially, either way, we go through the skin and muscle and all those things through the liver, a tract through the liver, and into the bile ducts. If the tube is placed in position above the ampulla, then it is considered an external drain. If the tube, however, goes all the way through the ampulla into the small bowel, into the duodenum, then it's considered an internal external drain. That language is just very confusing, but it's similar in concept to a nephroureteral drain, meaning that there are times where a patient, we have side holes all along these drains often. So a patient could be draining their internal ducts, meaning they're the ones inside the liver, intrahepatic ducts, can drain all the way down into the small bowel without having the tube to the bag. So there are times where you'll have patients who have a bag with an internal external drain because it's not adequately working to just go through the tube itself into the small bowel. And sometimes these patients will be capped. And so very similar to a nephroureteral tube concept. So again, how does an internal external drain differ from a biliary stent that you hear about from GI? And so back to this picture again, our tubes go through the skin and through the liver. And so we have, again, an external pop-off function, but disadvantage is the patient has an external portion of their tube, whereas with a biliary stent that GI places, or sometimes we place, everything is completely internal. The difficulty with biliary stents is sometimes GI can't get across the system because of prior surgery or things that keep them from being able to get through the ampulla or to target it. And also biliary stents need to be changed internally. And then third, the types of biliary stents that are placed are different depending on the patient's longevity. And sometimes we can't predict or don't know whether a patient has a malignancy or whether they have a benign stricture. And so that may change the pathway. Once we have that information, there are times where we just never get that information. We suspect it might be a malignancy, but no matter how many brushings and things that we do along the bile ducts, we may not get that information until they present with metastatic disease, for instance. So sometimes we continue to use biliary drains and not make things entirely internal because we don't know what the diagnosis is. And again, this information post-procedure is going to be very similar to nephrostomy tubes. So we can get transient bacteremia or biliary sepsis, typically not long after the procedure with the same signs, fever, tachycardia, and altered mental status. The one thing that is different with these patients, they often shake when they get transient bacteremia, and we have to use Demerol on, it seems to be the most effective for decreasing that. Patients are very uncomfortable in that period of time. So as soon as you give them like 25 of Demerol in the post-procedural area, they improve remarkably quite quickly. And again, typically by the time we send them to you all, they've passed that period of time. Bleeding can occur. It can occur anywhere along that path. So between the skin through and into the liver. So you can imagine we go through sometimes you could go through the intercostal space. You can go through anything along the liver. So it can be arterial or venous, and it's not necessarily in the liver. It can be outside of the liver. Again, patients have tachycardia, low blood pressure, decreasing hemoglobin, and altered mental status. We worry more in these circumstances that when we cross something in the liver that it may transiently bleed and it may create a pseudoaneurysm. And so those things can kind of give you a sentinel bleed and then stop for a little while and then rebleed. So CTAs can be very helpful, and we'll talk about that. These patients have a little bit more pain typically than nephrostomy tube placements. We often do these under general anesthesia, depending on the patient. Sometimes we do them with sedation, but they can be uncomfortable. Often they're intercostal low, but still intercostal, and that's very uncomfortable. But you have to distinguish that kind of pain from, is it bleeding or dislodgement of the tube? And again, you have to use those extra factors to be able to do that. A dislodged or obstructed tube, again, not usually right after the procedure, but it can happen. And the same exact things, you're not able to flush it. It's painful to flush. There's leaking around the tube. There's no output. And then here we rely a lot more on the T-bili. That tends to move faster when there is a non-functioning tube. And of course, also it could be signs of infection if they presented with infection to begin with. But typically we see a rise in T-bili sooner than we do with a creatinine, just because sometimes the other kidney is functioning well. In this particular circumstance, often we don't need a CT. So a lot of times we have our placement and we can see where the tube was. And typically, if it just moves a little bit, we know that it's no longer, especially an internal external drain, that it may not be in the bowel anymore. And that's why we're not getting the appropriate drainage. So oftentimes we can use just an abdominal x-ray for comparison to the previous position, either at the time of placement or a prior injection study. So key takeaways for this is, again, transient bacteremia, just like nephrostomy tubes, is common. Hemophilia is actually not as common as what we see with nephrostomy tube placement. So here I use the words as not uncommon because we do see it, but it's not expected, kind of like a nephrostomy tube. Some tidbits for if you happen to be around or get a call about a patient's biliary drain bleeding. If it's rapid, if it's bright red, and or they have a change in hemodynamics, of course, call us. But you can always clamp the drain. You can either just turn off the flow. Then the nurses know how to do this. Turn off the three-way, or you can actually physically put a clamp on the drain itself. And that's because if it's an arterial bleed, just kind of pressure tamponading it by doing that can be really helpful in those in that immediate time frame where you haven't been able to get us bedside or get the patient down to us. Also, again, just like with nephrostomy tubes, if a patient requires a transfusion, you definitely want to give us a call. We'll probably give you some advice to get a CTA, and that's because sometimes we see pseudoaneurysms, and it really helps with our treatment planning. Tube dysfunction may prompt imaging again to confirm tube positioning. Remember, just like with nephroureteral tubes, internal external tubes can drain internally. So look for other signs of dysfunction if you think that if you don't have any suspicion that these tubes were pulled back and they just have a difference in output. Again, it may be due to hydration status. It may be that the tube is actually functioning in a way that everything's draining internally. Again, an abdominal x-ray is usually good enough for comparison to placement or prior, and routine check or change of tubes unless there's a concern for biliary sepsis. Should I stop and just see if you have any questions about nephrostomy tubes, nephroureteral tubes, or the different types of biliary drains? You can save them till the end too if you want. Okay, if there are no questions, I'll talk a little bit about embolization. So embolization is blocking blood flow to an organ or a tumor via the blood vessels. We typically access either the radial artery or the femoral artery. And most of the time it's the opposite. It's either the right femoral artery or the left radial artery. The reason why we do the left radial artery is just we cross less of the arch vessels. If we go via the left radial artery, that's very different than what you see with cardiology. And that's just because the angle that they need to get into the cardiac vessels is actually beneficial from going from the right in many instances, depending on what they're doing. Whereas for us, it doesn't matter. We're usually going down to the mesenteric system in the belly or down into the pelvis. And so the left radial is safer from the aspect of what we have to cross. So you'll typically see a left radial artery access, or you'll see a groin access on the right side. However, if a patient has an abnormality in the right groin, or if we are trying to treat something that's more advantageous to go the left groin, we will. Examples of things that we embolize are uterine arteries. We embolize liver for either bleeds or tumors, kidney for same kinds of things, prostate, and many others. These are just some examples. We're going to talk about uterine artery embolization because those are patients that we typically admit to you, whereas our hepatic embolizations, they're usually either on trauma service or they go to transplant service if it's tumor. And some of the other things go to other services as well, often urology for some of those other things that I mentioned. But you typically get our uterine artery embolizations when they need to stay overnight. And so, first of all, uterine artery embolization is the generic term for embolizing the uterine arteries for a variety of different conditions. We do that for adenomyosis, for postpartum hemorrhage, for other things. But specific to fibroids, it can be sometimes referred to as uterine fibroid embolization or UFE. And that's how we'll refer to it for this portion. So women have fibroids all over their uterus, and they can be in various locations. And when we do a uterine fibroid embolization, essentially what we're doing is putting a catheter in the femoral artery, or like I said, the left radial artery. And depending on which direction we're coming from, we cross over into the uterine artery vessels and deliver these, what we call microspheres. They're on the micron level. They're like little grains of sand, essentially. They lodge into the blood vessels and starve the tumor. It's a benign tumor, but the tumor of its nutrients and oxygen, and therefore they become non-functional tumors. And in that process, as you can see here, when we're delivering this substance, it goes preferentially to the fibroids because they are so hypervascular, but we're transiently treating the whole uterus at the same time. So patients have severe pain after this procedure because they get some varying degree of transient ischemia to the uterus, which recovers. And we know that because on later imaging for the last 25 years, there have been studies that have shown their uterus recovers and doesn't become ischemic, whereas the fibroids do. But in that process, that can be very uncomfortable. So as I mentioned here, pain is the issue due to fibroid and transient myometrial ischemia. The peak onset of pain is usually 4 to 6 hours post-procedure. So if we do, and we try to do this, we try to have these patients come at our 5:30 a.m. arrival so that they can be first case. But some patients decide not to do that. And that can be really challenging to get them out on PO medications by the time, the evening rolls around. Whereas on patients who come first case, usually we're able to observe them all day. We start off with some IV meds. As they transition, they get to PO meds and we can get them comfortable before we send them home. Bleeding is extraordinarily unusual in these cases. And I'll just go back to the previous slide and say that if bleeding is going to occur, it's going to be from our access. Now, that being said, there are times where when we do an embolization procedure and we access an artery, that we access too high. And if we access too high because of some variant anatomy or something that threw us off, that could bleed into the retroperitoneum. So it's a bit confusing to say it would be external and you would see it on the thigh or see it on the wrist, but typically you would. We don't really create internal bleeding otherwise. So these vessels aren't fragile. We're not poking through them. There's no issue in that regard. So we're not getting uterine hematomas or anything of that nature. So just so when you're thinking about these patients, if they had a change in their hemodynamics, it mostly will be externally. There are rare instances where it could be internal because of a high puncture site that bleeds into the retroperitoneum. But bleeding in general is uncommon and should be external in most cases. Post-embolization syndrome is a bit of a blanket term that can be used for a lot of different embolization procedures, what patients experience, which is usually a triad of pain, low-grade fever, and increased white blood cell count. It can be very confusing because with some embolization procedures, patients are more likely, have some possibility of being infected post-procedure versus others. Typically, though, in the period of time that you see these patients, especially if it's a one-night stay, these patients are not going to be infected that quickly. So no matter really what embolization it is, it's very, very atypical. So if you see some signs of pain, low-grade fever, if they feel flu-like, it's probably not incredibly helpful to do what we typically would do if we think someone's infected, which is, get a white blood cell count, get imaging of some sort. And the reason why is because the white blood cell count will be elevated post-embolization on all patients for the most part. And the imaging for patients post-embolization, when we deliver what we do in embolization, it's normal to see streaks of air in the embolization bed. So if we image and there's air in a cavity where we just embolized, we don't know what to make of that essentially. So it really doesn't change our decision pathway in any way. And I would say put infection really low on the list if you're seeing somebody immediately post-embolization. So key takeaways: pain is exceedingly common. This is why we start actually medications even before the UAE procedure or UFE procedure. In the hospital, we use Toradol and ibuprofen outpatient. IV Tylenol when you can get it. I came from Georgetown and we used to use that regularly. I've had difficulty with the pharmacy here, but I just need, to sit down with them and probably go through some reasons why I want to use it. And hopefully we'll get some ability to use it going forward. But IV Tylenol can be really helpful for these patients. They respond very well to it, surprisingly. And then we use narcotics for breakthrough pain. The point being, though, that the anti-inflammatories are key for this process. When we do an embolization, we essentially stir up inflammation, cytokine release, all those things. So if these patients don't get anti-inflammatories in the hospital and scheduled when they go home, they will bounce back with pain or continue to have pain and be difficult to get out of the hospital. So these are the anti-inflammatories are the key to this. Bleeding is exceedingly uncommon, but look to the femoral or radial artery access sites. And then post-embolization syndrome can occur if you have the patient for a prolonged stay. It's very atypical in the first night or so after the procedure, and more so a few days in up to about a week. For that, either way, it's just supportive care. It's unlikely to help to get white blood cell count or imaging. And then finally, I'm going to talk about ablation. And I know that a lot of times these patients don't come to you all either, but you may see them for pain control or for concern that they may be bleeding after the procedure or different things. So ablation is essentially creating tissue damage intentionally with a probe from a percutaneous route. So you can see here This patient's prone, and this is us sticking a probe into the kidney. And there's a tumor here, which you can't see because there's not contrast on this image. But the point is, we've planned our route, we've put in a probe, and often there are multiple probes that it takes to either freeze or burn a tumor. And so this happens in the liver and the kidney and other soft tissue locations, but the liver and the kidney are definitely the most common. So post-ablation, you might imagine, since we cross lots of structures from the skin all the way to the vascular organ that we're treating. So bleeding can occur anywhere along that path, and the typical signs: tachycardia, low blood pressure, decreasing hemoglobin, and altered mental status. I will say that oftentimes when we're treating these, we actually watch the ice ball form, for instance, when we're using cryoablation. And so we can see that form. And when we pull out our probe, we rescan the patient, and sometimes we'll see bleeding already behind the kidney. And so we'll keep the patient on the table, we'll rescan, we'll go ahead and do a CTA, things like that. So we'll watch that patient and monitor them until we make sure they're not actually having an immediate bleed before we, ship them off to another service. So these patients, we may know that answer right away. If we did, we would just go ahead and take them straight to angio to stop it. Bleeding of that nature is very uncommon. Pain can be an issue, but usually isn't severe. So if there is severe pain, you might want to also consider, is it because there's a space filling up with blood? And then non-target tissue injury. So this is typically transient, but you have to be aware of adjacent structures. So for instance, sometimes we're treating, a kidney mass that's near the collecting system. And so if a patient all of a sudden can't urinate post-procedure or has significant hematuria post-procedure after one of these or something like that, we have to think, one of the things we're considering is, did we accidentally ding? Did we grow our ablation zone too much that it dinged a fragile structure like the ureter? I just put this in here because it's just a reminder that there's so many different things that can bleed around some of these organs, and kidney is definitely one of them. So you can bleed inside the kidney, and you might see that via, hematuria. But you won't see hematuria if it's bleeding around any of these spaces, if we cross an intercostal artery, or if it's just bleeding from a capsular artery behind the kidney. So, you might not see hematuria, and that can be misleading as to what's actually happening with the patient. So key takeaways for ablation: bleeding is the major immediate post-procedure concern, although it's not incredibly common. CTA is ideal, but sometimes we can just tell what space is the issue if we just have a non-con CT, just like I showed you with the probe placement. If we know where the hematoma is collecting, we may not need to know exactly what the bleeding vessel is, but where to search just by knowing the space. Pain is not uncommon, and you just need supportive care. Unless it's severe, then you want to think about, is there a space filling up with blood when patients are having hemorrhage? And then tissue injury to surrounding structures is usually transient unless it's a functional structure like the ureter. You can get transient lab elevation, and this is important. So patients who get a liver ablation, for instance, if you were to check their liver enzymes that night, and this goes for embolization as well, I should have mentioned it, they're going to have a transaminitis. And so these things are often not incredibly helpful unless you just want to trend them just for comfort and kind of knowing, where things stand. Those things typically, they're expected to go up, and they will get better over, a day or so, or a few days. So labs are often not really incredibly helpful. And that's kind of the theme of all of these patients. The one thing is, if you suspect bleeding, of course, you do the typical things, including checking the hemoglobin. But in most of our patients, some of the other labs can be very misleading, including a white blood cell count, including T-bili or liver enzymes, or even a creatinine, because they're not incredibly useful to tell us what's going on. They often are abnormal in a transient state. So I'll just open it up, of course, to questions about any of the things we discussed. I hope it was helpful. I hope these are some of the patients that you see. And also, things that you have seen come up, or anything, doesn't even have to relate to these specific procedures, but questions that you have about patients that we send to you, or any suggestions for improved workflow. I have been working with James Oliver on, well, he's doing the heavy lift, I should say. He's working on creating sort of I think basically an order to make sure there's, in addition to the phone call that we make to you all about admitting a patient, that there's some additional way to make sure we're communicating a patient's need to be admitted. And so he's working on some of that with IT. But I think, given everything that's going on in our world right now, it's a little delayed in getting into use.
Thank you for the overview. It was very helpful. Last month, we heard from someone with back pain, and he had mentioned the SIR guideline app. Do you have other resources you would recommend as quick references when 4 months down the road we don't remember all the details?
Yeah, that's a good one. So that's really helpful for, I think for anticoagulation type discussion. So if a patient is preparing for a procedure, I think that's where the SIR guidelines app is really helpful. And it's super easy to use. It's exactly what we go by. So if the SIR guidelines app says, hey, we can do this procedure with an INR of 3, then we do it with an INR of 3. And if it says we can't, we can't. And we try to stick to that with exceptions. Of course, there are some patients who just, I always say in IR, there's not any absolute contraindications, because there's just sometimes where an IR procedure is the only procedure that the patient can have. And so even if their INR is 5, if they need an abscess drain and they're going to die because we, don't drain their fluid collection, then we're going to drain their fluid collection. And so, their INR might not fit into the criteria. So there are times where that isn't used, but that app is very helpful for that reason. So our normal parameters for procedures are listed there, and also tells you specific, you can just choose what drug the patient is on. They'll tell you what the hold needs to be. So it's very helpful. In terms of resources for, what might be going on with the patient, I mean, I'm certainly happy to share this. I know it's not a quick reference, but it's one that you could utilize. I don't know if you have a shared drive or something that you guys keep this kind of information, but I'm definitely happy to share it. We are always a resource too. We are on 24/7. We just don't have someone in-house. A lot of times we are in-house doing other things like trauma. So, if you're not sure and you're uncomfortable, please call. We understand that and we expect that. So we're always able to answer those questions on the spot too.
I had a question about access. You mentioned sometimes, I'm not sure, you mentioned risk of retroperitoneal bleeding with high access in the groin. How do you handle, if you have to go high for altered anatomy or anything, is that ever intentional that you go? Do you use the inguinal ligament as a landmark, or do you try not to do any high access and use a radial side or a different, like a jugular venous side? Or are there times when you intentionally stick high, and how do you handle those?
Yeah. So usually if it's a venous stick and it's high, most of the time, even if it's a big hole, it heals relatively well because it's a low pressure system. So we tend to get away with, even if we have a sort of unintentional or intentional high stick for a venous side of things. So if we're placing a filter via the groin, for instance, an IVC filter, that's a pretty big sheath. And sometimes we stick on the high side for various reasons. The patient has DVT below it and they have DVT on both sides and they don't have an IJ. And, it just can be so many reasons why. But typically with venous sticks, we get away with a lot more. When we have to stick, or when we have concern about an arterial high stick, we will stick on the low side. The problem with sticking on the low side is you never want to compromise the function to the leg, of course. So we try not to stick into the superficial femoral artery. So we try to stay in the common femoral artery, but some people's anatomy is such that their common femoral is just really high. It's above the inguinal ligament. It's unusual, but you do see it. So if we see that by ultrasound and we can tell that we would require a high stick to be away from the superficial femoral artery, a lot of times we'll use the other groin or another access site. And I would say in the cases where we end up sticking inappropriately high, it would be accidental, just like you could, accidentally have any complication. Sometimes we don't recognize it as such. And, when you go into a room and the area is prepped, you get about this much space that you see. And, your landmarks can be thrown off sometimes if you're just looking at a very large groin, for instance. Those are some of the trickier ones. You just don't have your typical landmarks and you don't even see inguinal ligaments at times. So it can be a little difficult, but we try very hard to avoid making a high stick, and would in fact make a low stick more typically than a high stick for that reason. We also use closure devices. in most cases. Closure devices have risks too, so they're not done without consideration. But particularly, I mean, the patient population here in Alabama, we definitely have to think about their utility because they can be very helpful. It is very difficult to hold pressure on a large groin or know that you get hemostasis or be able to recognize when a bleed is happening in a leg that is, in a morbidly obese person. So it's definitely something that we have to think about and utilize. We do that in most cases. They can still fail and a patient can still have bleeding in the retroperitoneum if we were to, have a failed closure device. But we do take all these things into consideration when we're making our access.
Yeah, thanks. We do have a procedure service. We deal with venous access. I mean, we never do arterial access intentionally unless we might be placing the rare heart line, but
Yes.
we deal with the alternate anatomy because of, obese patients and things like that. But
yes, and you'll probably, on the venous side, it's very unlikely to have an issue, but not impossible. And again, one of the difficulties is in some of the patient population that we see here, it could go unnoticed for a while, for sure.
thanks so much.
Are you guys seeing other types of procedures? It's interesting because we've, kind of gotten to a point where, again, we try not to admit when we don't have to. And some of the things, when we have a G tube, for instance, we often try to send that to the service who ordered it. Or, these liver directed therapies, we often send a transplant and things like that. But I'm sure there are some procedures that, get kind of come through the holes and that you all may see that we didn't talk about today. So are there some that come to mind that you all see frequently? I tried to kind of make lists over the last few months as I saw patients be admitted to your service, what they were, and these seem to be the most typical.
Yeah, I can't think of anything beyond peg tube placement, and it's less that they're admitted to us as in they're on our service for other reasons and acquire, which I mean would be the case for all of the procedures that you do, but none stand out to me that I can think of that are frequent or I've seen, management challenges regularly.
Okay.
Yeah, same. I can't think of any like scheduled procedures. I mean, we do get a lot of filters and cholecystostomy tubes, and but none of them are scheduled admissions for us per se.
Well, is there anything else I can answer for you all? If not, thank you so much for having me. And like I said, I'm not sure if I'll type in this chat my email address, please. Anytime. I know there's a lot of collaboration between our services daily. And so if there's anything I can ever help with from the IR perspective, I'm happy to. And we really appreciate getting to work with you all. And, if we can, anytime we can improve things on our side, we'd like to. We definitely have a few efforts ongoing with James, as I mentioned, not only with the order set, but also working on some things out of the ER. And if you ever have any ideas along those lines for improved workflow, we can definitely work on those things together.
All right, that sounds good. Thank you so much for your time. We look forward to working with you more in the future.
Thank you too. Okay, everyone, have a great evening.
Right, you too.